Hello, this is Alan Gardner, Senior Lecturer in Advanced Clinical Practice here at the University of Central Lancashire. And welcome to this video lecture, An Introduction to ENT for Advanced Clinical Practitioners. My clinical background in Advanced Clinical Practice was primarily in ENT, and so I've tried to carry on this area of special interest into this role as a senior lecturer here at the university. And I really enjoy teaching about ENT, and a big part of this session and the day that this is associated with, so that, as you know, this lecture is specifically associated with the ENT teaching for the module HI 4503. And a part of that day is to try and put ENT on the map, basically, or at least place it a little bit higher on students' set of priorities. I think as far as specialties go, ENT tends to be somewhat underrepresented. I think that it's probably a specialty that a lot of people know very little about, unless people are working in primary care, in which case they tend to be exposed to the primary care side of ENT, whereas I worked in secondary care in ENT as a specialty within an acute hospital trust. And this is, as I say, somewhat an underrepresented specialty that a lot of people don't really know an awful lot about. And so what you tend to find is that once you do know that little bit more about ENT, that you tend to then you become quite quickly become a port of call for other people wanting some advice about ENT problems or any other sort of general interest about ENT as a subject. So what I like to do with this session then is to try and help you to develop a greater appreciation of ENT, or otolaryngology as it's referred to within the specialty, because as I was saying on a previous slide, that it tends to be somewhat underrepresented. I think even within medical education, students are only exposed to it in quite limited amounts, that the majority of the ENT exposure that medical students enjoy is through virtue of primary care, with only very little direct ENT exposure in a secondary care setting. So hopefully for you guys, you'll get a greater appreciation of the ENT as a specialty, and really hopefully sort of develop some enthusiasm for ENT as a specialty as well. So I mean, for reflecting on my personal experience prior to working in ENT, I kind of had this preconception that, well, it's all tonsillectomies and grommets and there's not much more to it, but actually it's a really vast subject. So we'll talk a little bit about about ENT as a specialty and some of its subspecialties, and I'll try and signpost you to some ENT specific resources that might help you if you start to develop more of an interest in ENT, or as I say, if you're working in primary care, then some of these resources will be useful for you to access to inform your primary care based ENT care. I'd like you to, well, we're going to spend a lot of time going through the fundamental anatomy and physiology of the ears, nose, and the throat, so that can underpin the actual physical examination that you'll be doing in class. It says here that you'll be able to understand some of the main principles of the comprehensive ENT health history and physical examination. So a lot of that is kind of out with this video itself, but as I say, this video forms some of the work in the run-up to the ENT day as part of this module HI 4503. So it'll help underpin that when we actually start looking at the health history and physical examination in a bit more detail. So yeah, as I say, we'll look at ENT as a specialty, then we'll look at the fundamental anatomy and physiology of the ears, nose, and throat, linking that to the history and examination where possible. Excuse me. So you've got the problem-based learning, or the online work that you do with your case-based discussions to do in the run-up to being in class. And then the afternoon will be all about the physical examination, developing those skills. So ENT as a specialty, The professional body of ENT surgeons is ENT UK. That's the British Association of Otolaryngology, Head and Neck Surgery. Interestingly, from the perspective of ENT surgeons, they actually see themselves primarily as a medical discipline, that the majority of ENT presentations are treated conservatively, even though logistically ENT tends to sit within the surgical division of acute trusts. So there's this really strong philosophy of treating people medically or conservatively wherever possible, and reserving surgery for those people who truly need it. That's because it's a very large specialty in terms of patient numbers, so that flow of patients coming through the service, and the majority of those patients, as I say, are treated conservatively rather than treated with surgical intervention. In terms of primary care, it's a very large, it forms a large proportion of presentations in primary care. This first reference here, Warren 2008, is a little out of date now, and when I was updating these slides, I couldn't find anything more up to date than that, but this suggests that back in 2008, 6% of people within the UK will seek help for sore throat each year, which is a significant amount of the population. And one of the other main ENT-based presentations is vertigo or dizziness. Really, vertigo and dizziness are two separate presentations, and it's important to be able to differentiate between those two, and we'll talk a bit more about those later on in this video, and we can touch on that in class as well. But vertigo is specifically dizziness and imbalance and symptoms that are related to the inner ear, whereas we know that obviously patients present with dizziness that can be caused by a number of other things associated with the neurological system or with the cardiovascular system, for example. But this contributes a huge burden to primary care. In terms of ENT as a specialty or its subspecialties, you can see from this list that it includes neuro-otology, which is all about the neurological functions of the inner ear. Skull-based surgeons, ENT skull-based surgeons who work alongside neurosurgical colleagues in order to perform surgery around the base of the skull. So in particular, this can be things like acoustic neuromas, although that in itself is a misnomer. So you might have heard of acoustic neuromas. More appropriately, we refer to them as vestibular schwannomas, and that's because they originate from the Schwann cells around the vestibulocochlear nerve, which is the 8th cranial nerve. Again, we'll talk a bit more about that when we get to the appropriate slides. You can see that pediatric ENT in itself is a subspecialty, and some ENT specialties are purely interested in the ear, so otology. Head and neck surgery is in itself a subspecialty that this spans both ENT and maxillofacial surgery, where surgeons are treating and operating on cancer of the head and neck. And even rhinology in itself is one of the subspecialties within ENT. But this isn't an exhaustive list, but hopefully this just helps to start to paint this picture of ENT as a whole, that it's much more than just general ENT that you might be exposed to through working in A&E or working in primary care, or even just the sort of the day-to-day ENT stuff that is occurring in sort of district general hospitals. There's large subspecialties around the country, and in particular we've got our regional head and neck centre within Preston Hospital. Our regional skull-based surgical centre is in Manchester. So these are big tertiary services as a subspecialty of ENT. So just for some signposting now for you guys to take advantage of some of the resources available to you here. As I said before, ENT UK is the professional body for ENT surgeons within the UK. Alongside this video are the original slides that you can access on Blackboard, and you can follow these links through to ENT UK, for example. A lot of the resources on there are specific to ENT in secondary care, so that their usefulness might be limited to just as the ENT masterclass below here, which if you follow that link, takes you through to a national initiative to provide ENT specialist training to those working in ENT. And there's some of those that aim specifically at ENT nurses and advanced practitioners, whereas others are more focused on doctors and more surgical based classes. This ENT SHO website is also an app, and I understand that's being updated currently, but that gives you some really useful at-a-glance information on that can help you to manage ENT presentations, in particular if you're working in A&E, for example, or if you find yourself, if you do end up working in ENT and you're covering on calls, or any other situation where you might find yourself dealing with urgent care or other ENT presentations, for example, urgent care centres, or if someone turns up in primary care with some of these common, more acute ENT presentations, such as acute tonsillitis. There's guidance there on managing peritonsillar abscess, which we'll talk more about as we progress through these slides. The next of one of these bullet points where it says EP3OS, the EPOS guidance, as you can see, is a little out of date now. So this is the European position paper on management of rhinosinusitis. So that's currently dated 2012. This organisation are currently updating this guidance, and they're aiming to release this in 2020, so this year. So the aim of this guidance is to help manage rhinosinusitis in terms of both acute and chronic presentations. So this is inflammation of the nose and the paranasal sinuses. Again, we'll talk a bit more about these as we progress through these slides. You'll have also heard of nasal polyps probably, and that is a result of chronic inflammation within the nose and paranasal sinuses. You probably will have heard of sinusitis. And actually, if you click the link through to the NICE guidance from 2018, that refers to sinusitis. But according to this European position paper from 2012, there is no inflammation of the sinuses without the nose, and so really the correct terminology we should be using is rhinosinusitis. Both of these documents can be really useful in informing your management, and there's stuff there that's specific to primary care management of both acute and chronic rhinosinusitis. As I mentioned before, ENT is a very large specialty, and so they warrant their own Cochrane database. Rather than accessing Cochrane literature through the main Cochrane website, you can access it through a specific ENT Cochrane website, and there's some examples there of the sort of thing that you might find. Again, there's some resources on there that are specific to secondary care for ENT, but there's also a lot that would be useful for those working in primary care or in more sort of urgent or emergency care settings if you choose to look at ENT more closely. So we'll move on now then to looking at the fundamental anatomy and physiology of each of the constituent parts of the ears, nose and throat. And we'll start with the ears. I'm going to try and link each of these elements to bits of information that help inform your history taking, and some links to the physical examination as well. Just most importantly for your physical examination really is to understand the underpinning anatomy and physiology, so then we understand what we're looking at and how that relates to the pathophysiology and the signs that we're trying to uncover. Throughout the examination of the ears, nose and throat, we need a systematic approach, and so we rely on our inspection and palpation with a few special tests, for example tuning fork tests that we'll talk about fairly soon, but for the most part it's about inspection and palpation. So we start with our inspection, and for all three of these constituent parts, our ears, nose and the throat, we always want to illuminate, and I'll stress the importance of that when we're in class practicing these clinical skills. So as we start our inspection of the ears, we're going to inspect the external ear first. On the next slide, I'll talk about the three different constituent parts of the ear. But to start with, we're talking about the external ear. Now that constitutes the the part of the ear that we can see just from the outside, what we call the auricle or the pinna, which is, as I say, the part of the ear that we can see externally, but it also includes the external auditory meatus as demonstrated on this diagram here at the bottom, all the way up to the tympanic membrane. So we want to illuminate our pinna and identify each of these landmarks. Now these landmarks are really important, and if you start looking at different ears, you'll notice that there's variations of what's normal, but people always have these key landmarks other than if they've lost them for whatever reason, which is why these landmarks are really useful, because we can lose them due to traumatic injury or infective processes. For example, if there's infection of the cartilage or the overlying structures around the cartilage that makes up the pinna, then that subsequent inflammatory response will mean that we no longer are able to see some of these landmarks. That's the same with traumatic injury. For example, if you follow the link in the slides to drainage of hematoma, you'll see some images of pinna hematoma as a result of traumatic injury. For example, in contact sports such as rugby or boxing or wrestling, where people will not only have sort of direct blunt trauma to the ear, but due to frequent rubbing of the skin around the pinna, and this causes a sort of shearing effect between the skin and the cartilage, which means that we get leaking of serous fluid and blood between the skin and the pinna, which then builds up to become either a hematoma, or over time it develops what we refer to as cauliflower ear, basically. So scarring, and you'll see in the images, if you follow this link, you'll see images of quite well developed cauliflower ear. Excuse me. So we get this loss of these important landmarks. You'll also note that these landmarks are useful for identifying specific lesions. So if there's, for example, skin cancer such as basal cell carcinoma or squamous cell carcinoma, we can identify exactly where on the ear these lesions are by identifying these specific landmarks. So if you're interested in evidence-based approach to drainage of hematoma, you can follow this link. And that will take you to a very comprehensive web article that shows different techniques and how to go about draining pinna hematomas. Obviously, that should be underpinned with the appropriate practice-based, work-based competencies for that, if that's going to be part of your role. But it's certainly interesting to see, and probably one of the most important parts of this is the use of the pressure dressing to stop the reaccumulation of the hematoma. So this diagram here demonstrates all the three constituent parts of the ear, starting with our external ear. So as I said before, the external ear starts from this line here, which is what you can see on the outside of someone's head, the pinna. We've got our external auditory canal, where sound travels down the external auditory canal toward the tympanic membrane. So we end our external ear here. Now this is where our middle ear starts. So if I draw this blue arrow here toward the middle ear, what we'll see on the next slide is that our middle ear is made up of our tympanic membrane, which is here, and our three ossicles, the bones of hearing. Now you might have heard those referred to as the hammer, the anvil, and the stirrup, but the appropriate names are just here, the malleus, incus, and stapes, the three smallest bones in our body, and they're responsible for, they vibrate under stimulus of sound. So as sound waves travel down the external auditory canal in this direction, that they bounce against the tympanic membrane or eardrum, and they send this chain reaction of vibrations down our ossicles, these bones of hearing, through the middle ear until our final bone, the stapes, which abuts to the cochlea, which is where our inner ear starts. So we now have the inner ear that starts here, which is made up of our cochlea, the vestibule, and the semicircular canals. And it's the cochlea that's responsible for transforming this this vibrational sound wave. It transforms it into a neurological system that travels down the 8th cranial nerve, our vestibulocochlear nerve. It says the audiovestibular here on this diagram. It's actually incorrect, that we refer to it as the vestibular cochlear nerve. It has a vestibular branch and a cochlear branch. Now the cochlear branch is actually the element of it that's responsible for transmitting neurological signals associated with sound all the way to the brain where sound is interpreted. We'll talk a little more about the inner ear when we get to that point next, over the next couple of slides. This next slide demonstrates what we're able to actually observe when we inspect the ear using an otoscope. So we use our otoscope, we place a speculum into the patient's external auditory canal so we can inspect the skin of the external auditory canal, which can become inflamed through infective processes. We refer to that as otitis externa. One of the main things we're trying to observe is the eardrum itself. Now on the previous slide, we were in the diagram, we could see the tympanic membrane from a coronal view, but now we're observing it actually down the ear canal. We're looking at it sort of face on, as you will, so it appears in this disc shape, and you can actually describe the presence of lesions such as perforations, holes in the eardrum, and you can describe those in terms of a clock face. So if I draw a circle around our tympanic membrane here, that as you see, it's this disc shape, and so we would have obviously 12 at the top, 6 here, 3 to the right, and then 9 o'clock here, and you can orientate yourself in this fashion in order to identify the position of certain lesions. Now, as with all our physical examinations, we need our landmarks so that we can identify what's normal, and we can orientate ourselves to normal variations between the left and the right ear, for example, or just from person to person. And these are annotated on this image here, that we have our it says lateral process of Malleus, or we might refer to it as the handle of Malleus, so we can actually abbreviate that as HOM. So that's our handle of Malleus, which is this landmark here. So we draw a line around this. So this is actually the part of the first of those bones of hearing. As I say, they're referred to as the ossicles. So it's the first of our ossicles, the Malleus, that actually attaches to the tympanic membrane. It draws it in toward the middle ear. So as we're looking at this with our otoscope, what we're doing is we're observing it with no depth perception. So we're observing it in just 2 dimensions, and it can be difficult to tell that actually it's drawn inward. And on the next slide, we can see that demonstrated actually, that it's at an angle, and that because it's attached to this handle of Malleus, as I say, it draws it inward. And so that forms this, what we refer to as the cone of light, or the light reflex. So as we're looking at this eardrum, the tympanic membrane, we're shining a light at it through our otoscope, and that light bounces back at us from a specific point. So we know that this is the patient's, particularly this diagram is the patient's right ear, and we can orientate ourselves through the position of the handle of Malleus here and the position of the cone of light. So as we're looking at this diagram, we know that this is the patient's right ear. So if we imagine that the patient's facing to the right of the screen and the back of the head is toward the left, whereas if it were the left ear, it would be mirrored the other way. And actually on the previous slide, although you're watching this as a video, if you look at the slides, you can follow the link to a video. It's just a YouTube video, but it shows otoscopy in both ears, and you can see that that mirroring of the left to right ear. And you can also actually see in that video that there is some variation between individuals' left and right ear, which is why with otoscopy, actually we always start with what you might refer to as the good ear first. So if a patient has a unilateral problem, then we would start by looking in the good ear so we can orientate ourselves to what is normal for the patient. But even so, you might see some slight differences between the patient's left and right ear. The other two important landmarks for you guys to learn, they're not the only remaining landmarks. There are some others that you might learn as you progress your otoscopy skills. But for the meantime, if you just focus on these four, that's a really good start. So we have our handle of Malleus, our cone of light, and then these other two. It refers to the pars flaccida. So I'm going to change color now, just draw this sort of upper region here. The pars flaccida is this upper quadrant of the eardrum, and it's referred to the pars flaccida because it's not as tightly stretched as the rest of the eardrum, which is the pars tensa. So actually the pars tensa basically is the rest of the eardrum it's pulled tightly like the skin of a drum, basically, so that it resonates and is able to transmit this this vibrational sound wave down the ossicles toward the cochlea. So if you're interested in learning some other landmarks, I'll use this purple color just to outline some of these. So what we can see then is this shadow here, and we refer to that as the round window. So what we're actually able to see is that we're looking through the tympanic membrane, that it's actually translucent, that a normal tympanic membrane is described as having this sort of pearlescent, translucent color, or a pearlescent color. It's slightly gray and it is translucent, so we can see through it to this round window. Now the cochlea itself, it has two windows. It has an oval window, which is a membrane that the stapes sits against, and it allows it to transmit the vibrational sound waves into the cochlea, that then stimulates hair cells that then transmit that sound down. They transform it into a neurological signal and transmit that toward the brain. And we can also look at this round window here. Because the tympanic membrane is translucent, you can also see this, what we refer to as the long process of incus. Okay, so a long process of incus. So what that means is that that's actually the second of the three bones of hearing that you're able to see sort of in the distance behind the tympanic membrane. But as I said before, if you guys just focus on learning those four key landmarks, that being the handle of Malleus, cone of light, the pars tensa, and the pars flaccida, that's a really good start for orientating yourself to otoscopy and starting to understand some normal anatomy as you're looking in people's ears. So considering that the middle ear then, as I was saying before on this slide, you can see how the tympanic membrane is pulled backwards by this handle of Malleus here. The tympanic membrane is attached to the handle of Malleus and it's drawn back, and it becomes this sort of concave disc, I suppose. And that then, because this is pulled tightly, it allows sound to travel down these three bones of hearing toward the cochlea. Now you can see from this this diagram then that the ossicles exist within this space referred to as the middle ear space. And this is filled with air. So this needs to be filled with air to allow the ossicles to vibrate and move. And so there's a connection between the middle ear, and the outside world. Now, in this diagram here, it refers to as the auditory tube, and I'll actually refer to it as the eustachian tube. The eustachian tube, okay. So this is it's actually a bony tube that's surrounded by mucosa, or lined with mucosa, that connects the middle ear to the posterior nasal pharynx. And it's this eustachian tube that allows us to equalize the pressure within our ear. For example, as the air pressure around us changes. So the typical example is as you go on a flight, and I'm sure you've all experienced this, that feeling of, we refer to it as your ears popping, sort of colloquially. So you feel that you can sense that change in pressure as we go up in an airplane. The air pressure around us decreases, and so we've got a higher air pressure within the middle ear, and so we need to release that pressure, and air travels down the eustachian tube toward the back of the nose in order to equalize that pressure. And then as we come back down during landing, the air pressure around us increases, and so we need air to be able to go up through the eustachian tube in order to equalize that pressure between the middle ear and the external world. Now, the clinical significance of that is that because the eustachian tube is lined with mucosa, it can become inflamed, and so it can then become blocked. And so as secretions then are unable to leave the middle ear, we can also have pathogens introduced there, and so that can result in inflammation and in infective processes within the middle ear space, and we refer to that as otitis media. So you might see acute otitis media, which is inflammation and infection within the middle ear space, and this can be either caused by viral or bacterial pathogens. And as you can imagine, that would then create an increased pressure due to fluid buildup within the middle ear, so usually infective fluids. Our view of the tympanic membrane usually then becomes red due to inflammatory processes. We get an increased vasculature present within the tympanic membrane, so it becomes very red, and it can even bulge outward as well. So instead of being drawn backward toward the ossicles, such as in this diagram, it becomes bulging, and the end point of that can be that it what we call suppurates or perforates, and so this fluid that's within the middle ear can then rupture the tympanic membrane, and so we get what we refer to as suppurative otitis media, which is an infection within the middle ear that has actually bulged the tympanic membrane such that it's then ruptured and the fluid leaks through the hole within the tympanic membrane. Once the infection is managed, such as through antibiotics, or if it's just a viral infection, then with time, but usually suppurative otitis media would be a bacterial cause. And so if it's a small tympanic membrane perforation, then once the infection is managed and the tympanic the perforation becomes dry, so no longer infected, small perforations can heal themselves over a period of several weeks. I think it's usually about 6 to 10 weeks, whereas larger perforations will need surgical management. So if in the presence of a tympanic membrane, people need to, in the presence of a perforated tympanic membrane, people need to keep their ears dry, so they need to stop water from going in there. For example, when they're in the shower or bathing, or if they swim, then they need to wear earplugs, because if water travels through the tympanic membrane, it can reinfect the middle ear, and that'll impact on the healing of the perforation. Excuse me. Another important pathology of the middle ear that you might come across is what we refer to as cholesteatoma, and this is accumulation of keratin in this attic region here. So I'm just drawing this into the diagram, and keratin doesn't naturally occur within the middle ear. We don't know exactly how it finds its way there, but potentially traveling up the eustachian tube. Once it accumulates within the middle ear space, it grows into this cholesteatoma. So that's spelled C-H-O-L, cholesteatoma, like this. Okay, just in case you want to Google that and look at images. And so as that forms within this, what we refer to as the attic region of the middle ear space. It will actually erode this bone here. So this is part of the temporal bone, and it actually erodes through here and will be seen eventually bulging out through the tympanic membrane, through the pars flaccida, and will actually be visible on otoscopy eventually. What we tend to find is that patients will present initially with symptoms similar to otitis externa, which is inflammation of the external ear. So they'll have an ear canal that's full of pus, and it can present in a similar way to otitis externa. But with cholesteatoma, it tends to be unilateral. So otitis externa, which is infection of the external ears, usually occurs as a result of pathogens being introduced into the external auditory canal, or changes in pH of the external auditory canal. For example, if people change shampoo, they might find that changes the pH in their external auditory canal, or if they go swimming frequently and the swimming water introduces pathogens to the external auditory canal, which is why we tend to find that that's a bilateral presentation, whereas cholesteatoma may be unilateral. And so if we're seeing people with recurrent otitis externa, and in particular if it's unilateral otitis externa, then we should be highly suspicious of this cholesteatoma here. So moving on to the inner ear. So we've covered the external, middle, and now we're going to look at the inner ear and how this functions. So we've said then that the external and middle ear help to conduct, and that's an important word, it's part of our conductive hearing, that it conducts sound waves down the external auditory canal to the tympanic membrane, where it causes this sort of chain reaction of vibrations along those three bones of hearing, the ossicles, where the third ossicle, the stapes, abuts to the cochlea at the oval window, which, as I said before, is a membrane where the vibrational impulses that travel down these ossicles then stimulate the cochlea in order to form a neurological signal that then travels to the brain, and we perceive that as sound. So our inner ear is often referred to as the labyrinth, and that's what you're seeing here on the left. And this is I think quite a strangely beautiful organ, and it's got quite an iconic look to it, such that you'll see it portrayed in art and popular culture as well. So on the top right of the screen here, you can see one of many sort of artistic renderings of the inner ear labyrinth, and you can even see it, as I say, cropping up in popular culture, for example, on this album cover for the band Dillinger Escape Plan. But in terms of function, then, that it's a bony organ. It's that the inner ear itself, the labyrinth, is made up of three constituent parts. If we look at this black and white diagram to the left of the screen, you'll see that we've got this sort of snail shell looking organ to the right, which is the cochlea, which, as I said before, is responsible for the sensory neural component of our hearing. So as I was saying before, that our external and middle ear are responsible for the conductive element of our hearing. That our cochlea then transforms that into, well, it's a sensory organ, and it transmits neurological impulses toward the brain. So it's the sensory neural component of our hearing. The other two constituent parts of the inner ear labyrinth, then, if we go to the left side of this diagram, we have our semicircular canals. So you'll see at the top of this diagram, we've got our superior semicircular canal. We've also got our posterior and lateral semicircular canals. Now, as I was saying before, that this is a bony organ. So within the bony part of this is a membrane. So this is a hollow bone. Within that is suspended a membrane, and then within the membrane is fluid that travels around for example, around the cochlea, but it also travels around these semicircular canals. And then the third part of it, which is our vestibule, which is this sort of central part of this organ. And this is all filled with fluid that responds to different stimuli. And we've said then that our cochlea, the fluid within the cochlea responds to these vibrational signals that are sent through the ossicles, and then that vibration is transmitted through the fluid that fills the cochlea. And the cochlea itself is lined with these small hair cells. Okay, these small hair cells here, and in fact these hair cells are present throughout the whole of the inner ear. The hair cells within the cochlea specifically respond to these vibrations from sound, and so as the fluid passes over these hair cells, it stimulates them, that the hair cells move, and that it's these hair cells that are then able to provide an action potential that travels down the cochlear branch of the 8th cranial nerve. The hair cells that are present within the semicircular canals, they respond to different stimuli. So these are responsible for feedback on head position. And what this means is that as we move our heads, the fluid within these semicircular canals moves, and it stimulates hair cells within each of those. So we have these 3 semicircular canals that are all orientated in different positions. That actually the whole of this organ, remember, is mirrored from left to right, so we have one on each side, and these 3 semicircular canals correspond to different head movements in different planes. So, for example, as we move our head side to side, that will stimulate the lateral semicircular canal. So this is really important in helping us stay orientated in space, that you now start to appreciate the role of the inner ear in terms of balance. So by this point in the module, you guys have already studied the nervous system and start to get an appreciation for the inherent complexities of the nervous system and all the various stimulation or stimuli even that we respond to as part of our nervous system. And this all contributes to keeping us upright on 2 feet. That actually our existence as bipedal organisms is fairly unique, and so we rely on a very complicated neurological system to keep us upright, that we rely on proprioception in our peripheries. So for example, proprioception in our feet and our lower limbs that help us understand where our limbs are in space. That we have sensory feedback from our cervical spine, that we actually have reflexes that exist between our inner ear and our spine that help us respond to different head positions. We also rely on what we refer to as feed forward from our eyes. So as the world moves around us, that we get this feed forward on what's going on around us that helps us to maintain our position and stay standing, basically. So these 2 tiny organs play a really important part in helping us maintain our position and in providing this sensory feedback to head movement. And so if things go wrong with these organs, then they can have a really profound effect on people. That if you've ever experienced vertigo, that it can be this very strange and unnerving, unbalancing experience whereby the world can spin. It can spin horizontally or vertically, or even some people just get a sensation of the either them moving or the world moving. If you've ever had motion sickness, that this is associated with the inner ear as well. Although it's difficult to say in isolation sometimes, because as I said, this tiny organ is part of a very complex set of systems that all contribute our sort of balance system as a whole, really. Another good example is that there is a reflex between our inner ear and our eyes. It's called the vestibulo-ocular reflex. And this helps us to maintain our position, our eye's position in space as we move our head. So if you are able to fixate your vision at a particular point and then move your head left and right, that you can maintain that fixation on a particular point, and that's entirely due to this vestibulo-ocular reflex, and your semicircular canals play a role in that. So whereas these hair cells within the semicircular canals are free to move around in stimulation to these to the movement of fluid within them, we also have hair cells within our inner ear vestibule. Now, our inner ear vestibule is it's actually made up of two tiny organs. So our inner ear vestibule then is made up of the utricle and the saccule. Okay. Now, you don't really need to remember this. This is all just information that I think is really interesting and just helps get a complete picture of how our ears work and how they contribute to keeping us upright and what might happen if things go wrong. So the utricle and the saccule are two distinctly different organs, but both work in a similar way. They're referred to as the otolith organs. And what that means then is that these hair cells are actually weighted. So I'm just going to draw these little crystals on here. Okay, so these hair cells are weighted with calcium carbonate crystals. So they function a little differently to the hair cells within the semicircular canals. Because they're weighted, that allows them then to respond to linear acceleration. So the utricle is sensitive to linear acceleration. So as someone, for example, accelerates rapidly in a car, or again, we're going to use an airplane as an example, that you can sense that you're accelerating forward due to the movement of these calcium carbonate crystals within the fluid in the utricle, and they stimulate these hair cells that then send a neurological signal telling us that we're moving forward rapidly. Whereas the saccule works in a similar way, but that responds to vertical acceleration. So for example, if you are in a really fast elevator that's going to take you up really rapidly, that these calcium carbonate crystals will move differently, stimulating these hair cells, again telling us that we're moving. Now, where this becomes clinically significant then is if these calcium carbonate crystals become dislodged, and if they find their way into one of the semicircular canals. Now that can happen due to people being spun round really quickly, such as on fairground rides, or if they've had a bump to the head, or sometimes it can just be idiopathic, and if they find their way into one of the semicircular canals where they're not really supposed to be, they can contribute to basically the semicircular canal telling our brains that our heads are moving even though they're not, and so people experience that as vertigo, and that's a specific type of vertigo referred to as BPPV. So that stands for benign paroxysmal positional vertigo. This is the most common type of vertigo, and anyone working in primary care has probably seen this. Patients complain of very rapid onset of the world spinning around them, and it usually lasts a few seconds up to a minute. Any longer than that, and it's probably not BPPV, but it'll come and go of its own accord, and it's usually, well, it's associated with head position. So if it's the left ear that's affected, as people turn their head to the left, or they roll onto the left side in bed, for example, they'll complain that the room suddenly starts spinning and then it settles after a few seconds to a minute. And that's because of these calcium carbonate crystals. They're referred to as otoconia, that they find their way into the semicircular canals, and they produce this illusion that the world's spinning around us. And you may have seen people undergo what's referred to as the Epley maneuver, which is whereby a clinician or a physiotherapist might take a patient's head through specific movements in order to drain these these crystals, these otoconia, out of the semicircular canals and back into the vestibule, where they're not going to cause as many issues. The majority of vertigo, though, just gets better on its own, and the reason for that is that our neurological system has this inherent plasticity, and what that means is that it can adapt to false stimuli, and so over time it can adapt to these false signals, and so allow people to then not experience vertigo. And actually, in terms of physiotherapy, that's the physiotherapists working with what they call vestibular rehabilitation therapy will give people exercises that are intended to actually drive that adaptive response and stimulate this this neuroplasticity in order to help people overcome any false signals from a misfiring inner ear vestibule or semicircular canals. On the next slide, there's some links to tuning fork tests, which are clinical exams that you can do in any setting, as long as, well, any setting that doesn't have too much background noise, and they will help you to be able to differentiate between a conductive hearing loss and a sensory neural hearing loss. So far we've talked about the role of the external and middle ear and the way that they conduct sound waves through the mechanisms of hearing. And we've also talked about the inner ear and how the cochlea is the sensory organ that converts those sound waves into a neurological signal. We can use tuning forks to, as I say, differentiate between conductive hearing losses and sensory neural hearing losses, and we'll talk more about those in class. You can follow the links that are in the next slide to watch an online video that I think does a good job of explaining about these, but it doesn't really make that much sense, I think, until you get your hands on the tuning forks and you can go through the exams properly. Aside from the tuning fork tests, we also have audiometry, and the gold standard test for hearing acuity is the pure tone audiogram, and you can see this chart on the right, which is the chart that's used to document hearing tests. So along the x-axis, so along the bottom, we have frequency, so from low pitch sounds up to higher pitch sounds, and then on the y-axis we have the volume expressed in decibels, so from very loud sounds at the bottom to very quiet sounds. Now on this chart it says normal hearing is between 0 and 20 decibels, and actually as a rule of thumb you'd say normal hearing. The normal hearing threshold is actually around 30 decibels for adults. For children you can expect their hearing to be more acute, and so you'd expect them to be able to be closer to this zero line. And you're probably thinking, well, how can you get 0 decibels, because surely that's absolute silence, but really there's no such thing as absolute silence, really, not as far as we can perceive in normal conditions. So really this is more to do with just calibration of the machines, really. So we say then that normal hearing is around this 30 decibels mark, and the way that the audiologist will perform this test is that they'll start with some key frequencies at volumes that they'd expect you to be able to hear, and then they basically work quiet. They get quieter and quieter as they ask the patient to respond to each of the tones in the headphones, excuse me, until the patient stops responding to the sound, and then they get that little bit louder, so then they can record essentially the quietest sound that someone's able to hear at a particular frequency. So for normal hearing in an adult, a hearing test might look something a little bit like this. Those red circles denote the right ear, and then so normal hearing would also be expressed in the left ear, and so it would look something like this. So we're looking at around that sort of 30 decibel line in 3 key frequencies. If I just erase these marks, we can see how a pure tone audiogram is used to differentiate between sensory neural and conductive hearing loss. So for example, they might test the right ear and find that someone is able to hear only quite loud sounds along all these key frequencies, but in the left ear they might find that that is normal, so we'll express that with those crosses here. So then we've got a unilateral hearing loss. But you'll notice from these symbols on the left in particular where it says bone, masked and unmasked, and we'll talk mainly about masked bone conduction. So when we have a hearing loss, we want to know whether or not, what's the cause basically. Is that caused by problems in the external and middle ear, for example, a hole in the eardrum, or a problem with one of those bones of hearing? They can become calcified or sclerosed, so they don't conduct sound waves very efficiently. That's called otosclerosis. So in that case, that would be a conductive hearing loss. But this hearing loss, as it's expressed on the chart currently, could also be because of problems with the cochlea. For example, if someone has been exposed to ototoxic medication, for example, I mean, usually that would be systemic. It would be unusual for that to be expressed just in one side. So it could also be this hearing could be due to a problem with the 8th cranial nerve. For example, we mentioned vestibular schwannoma earlier, and so we use this bone masked conduction. And if you've had a hearing test in the past, you might have had them place the little panel behind your ear, and they place that onto the mastoid process just behind your ear. It's that bony prominence that you'll be able to palpate quite easily behind your pinna. And that sends sound waves through the temporal bone directly to the cochlea. So we call that bone conduction. Our normal method of hearing is via the external and middle ear, and we call that air conduction. And if we send sound straight through the bone to the cochlea, we call that bone conduction. In which case, if this were a conductive hearing loss, they might record, let me just swap colours. So I use the red to denote the right ear, so they might record that through bone conduction we would then have normal hearing along these key frequencies, and so that tells us that although what the patient is able to hear is decreased, that the cochlea and the nerve of hearing, the cochlear nerve, is still intact, whereas if this were a sensory neural hearing loss, then we would see that there wouldn't be a difference between what the patient's able to hear and what is picked up on bone conduction, in which case we would then see a pattern like this. Now, I'm actually oversimplifying this, and the idea of being able to hear consistently throughout each frequency, each of these frequencies, is actually not quite accurate, and that we know that different presentations or different conditions actually change your hearing in different ways. For example, glue ear in children actually is expressed as a fairly sort of mild to moderate conductive hearing loss in these lower frequencies here, but it would actually preserve the higher frequencies. So well, that's one example. I'm not going to talk too much about hearing tests, because I think this is just sort of knowledge that's interesting and good for you to know, but for the majority of you, you're not really going to need this. And if you do find that you need to know more about audiometry, then please come and speak to me, and anything I don't know about, I'm sure I can find you the right audiologist to chat to, who will be able to help you with that. This is the slide where if you look at the actual slides for this, then you can follow this link to a video that explains these tuning fork tests. We've got two of them, Weber's and Rinne's test, and they can both be used, as I said before, to differentiate sensory neural from conductive hearing losses in any clinical environment if you don't have access to pure tone audiometry. That brings us to the end of this section on the ear. We can now move on to discussing the nose. Similar to our approach with the ears, we want to make sure that we can illuminate for our examination. and we're going to use our inspection and palpation of first of all the external structures of the nose, and then we're going to move into the internal structures of the nose. So you can see here externally that we have our common landmarks again. Again, this is similar to the examination of the of the ears, that we have our common landmarks, and these are useful for identifying abnormalities. That if we can identify our key landmarks, then we can identify where lesions are. We can identify if there's any loss of these landmarks, such as after traumatic injury. As you can see from this diagram on the right, that our nose is made up of a bony part. So we've got our nasal bone superiorly with our cartilaginous part inferiorly. So being able to differentiate a true fractured nasal bones can be really tricky, especially immediately after the event, because we tend to get some immediate swelling around the root and the sort of external bony part of the nose. So they become swollen very, very quickly, and so being able to identify a true fractured nasal bones is quite difficult within the first few days. Clinically, it's also important to remember that if you've got a patient who you're querying whether or not they've fractured the nasal bones, that this is also a head injury, so they need to have all the same advice that any other head injury patient would receive if they're being sent home from the department. If there's no other focal neurological signs and you're happy for them to go home, then yeah, they need to receive the same advice as any other patient. Moving on to the internal structures of the nose, that we can see from this diagram on the left, we can still see the nasal bones here. We can see that we have our cartilaginous part here. What we're seeing, or what we're not seeing even actually, is the mid septum, the dividing septum, which we can actually see on the right side over here. So this is the cartilaginous septum that divides the left and right side of our noses. You can see that there are these bony projections internally, which are our turbinates. We've got 3 of these, our inferior, middle and superior turbinates. Now, our nose provides us with our primary airway. As babies, we only know how to breathe through our noses. It's actually a learned behavior to be able to breathe through our mouths. And you only need to spend a night, for example, with a blocked nose to breathe through your mouth to realize that our oral airway isn't equipped with the same function to be able to warm and humidify the air. So that's why we wake up with a very dry mouth and a sore throat. In comparison to being able to breathe through our noses, it's also a lot quieter. And these turbinates provide an increase in surface area. So they're bony projections from the lateral surfaces of the nasal cavity, and they project inward toward this midline, this septum. But they're also covered in mucosa, so they increase the surface area within the nose to be able to maximize the humidification and warming of the air that we breathe, so that whether we're in cold or hot environment, if we're in a very dry environment, that by the time the air reaches our lungs, it should have reached body temperature of around 37 degrees, and it should be 100% humidity as well. So these turbinates actually also, as well as increasing the surface area, they create turbulent flow of air within the nasal cavity as well. Posteriorly, on the left here, you can see the opening of our eustachian tube that we mentioned, that's the tube that connects the posterior nasal pharynx to the middle ear. These diagrams on the right here, you can see that we have a series of what we refer to as paranasal sinuses. So I mentioned earlier this idea of rhinosinusitis, and you can see from this diagram that they're intrinsically connected with one another, that we have this series of hollow air-filled spaces within the bones of our skull that connect to our nose. So for example, our maxillary sinuses here, this is the hollow space within our maxilla bilaterally, so our maxilla being our cheekbones, and that these are lined with mucosal membrane with cilia. So the ciliary action drains mucus out of the sinus into the nasal cavity here. So the maxillary sinus drains through this partition here referred to as the middle meatus. So there are meatai between each of these turbinates. Interestingly, the only thing to drain into the inferior turbinate is the lacrimal ducts. This is the nasolacrimal duct, and this is essentially draining tears, and helps explain why our nose runs when we cry. So if we have some inflammatory process going on within the paranasal sinuses here, that as we become congested or inflamed around this meatus, that will stop mucus from being able to drain from the paranasal sinuses into the nose. And I'm demonstrating this on the maxillary sinuses, but it could be from these frontal sinuses here. And so they need to be able to drain into the nose, and if they can't, then we get a buildup of pressure within the paranasal sinuses, which is why people with rhinosinusitis will complain of a distinct pressure type pain within the face, or they'll complain of headaches. That's because these paranasal sinuses are very sensitive to pressure changes. Clinically, you can even ask people to bend forward and sort of place, if they're sat down, and place their head between their legs and see if that brings on their pains, and that's a good clinical indicator of this being rhinosinusitis. As well as breathing, you guys have also studied the cranial nerves by now, that we also know that our nose is important for our sense of olfaction, that we have our cranial nerve 1, so CN1, which is our olfactory nerve. So this originates in the superior nasal cavity here with our olfactory filaments that then travel through what we call this bony part here, and it's called the cribriform plate, where it then becomes the olfactory bulb here, and then it proceeds into the frontal cortex of the brain, where olfaction is processed. Because you can see that these olfactory filaments travel through the cribriform plate, you can understand then that in head injury, if we have movement of the brain within the fixed skull, the fixed box that is the skull, that it can actually shear these olfactory filaments. That explains why people can complain of a loss of sense of smell or anosmia as a result of head injury. These 3 CT scan images are intended to demonstrate some pathologies of the nose and paranasal sinuses. So this first one here on the left, this actually demonstrates normal findings on CT scan. I'm going to caveat all of this actually with, now, I'm no radiologist, and I'm interpreting these as best I can based on where I've found the write-up about these on the internet. But this is certainly my understanding of these images anyway, that we have normal findings here, that we have our right and left maxillary sinuses, and they are filled with air, which shows up as black on a CT scan. And you can see that we've got good airflow around these turbinates here, that you've got this black all around the turbinates. You've got the midline septum nice and straight down the middle with no deviation and no blockage of mucus coming out of the maxillary sinuses. You can also see some of the ethmoid air cells there as well between the eyes. So that shows that we've got good clearance of the mucus within the maxillary sinuses and within these ethmoid air cells as well. Contrary to that, we have this second image, which shows that we've got some grey mucoid tissue here, or mucoid matter within the maxillary sinuses. This too could potentially be normal. As I said before, that I'm no radiologist, and so this is really just to demonstrate that we can find that this is sometimes normal, but it's also consistent with a picture of someone who has chronic rhinosinusitis, where the mucus is building up within the paranasal sinuses, and that sort of helps to demonstrate this sort of chronic inflammation within these sinuses. This third image on the right is intended to demonstrate the importance of unilateral presentations. Something I haven't really mentioned yet is that in ENT, they take unilateral presentations really seriously. I mentioned the cholesteatoma with regard to the ears, and now what we're seeing in this image here is it's the left of the image, but this would actually be the patient's right maxillary sinus that's showing up black, with good airflow around the sinuses and within the right side of the nose. Contrary to that, we have on the patient's left here this grey matter here that would be consistent with nasal carcinoma. So we've actually got some erosion of one of the turbinates here, and that the most common carcinoma in head and neck cancer is squamous cell carcinoma, and that would actually start to erode the bones of the orbit. It's eroded the middle turbinate here, and possibly even the superior turbinate as well from this image. And so, as I said before, this serves to prove a point that as you're examining noses, if you find that you can see something abnormal, it's unilateral, if your patient has really strong unilateral symptoms within the history, then that should start to indicate that you're going to refer them quite urgently, potentially a 2-week wait referral to ENT. Continuing that idea is this idea of nasal polyposis, or nasal polyps you'll have heard of. Now these are bilateral. Polyps are by nature bilateral. I said earlier that these are caused by chronic inflammation within the nose and paranasal sinuses, where they may at times seem to be unilateral, in which that could be because you're only able to visualize on one side. If we look at this this diagram on the right, for example, you might have a grade 1 polyp on the right side and a grade 3 polyp on the left, in which cases you're examining the nose with what we call anterior rhinoscopy, which we'll cover in class. That's essentially looking up the nose and shining a light up it to be able to observe the internal structures, but without going any further than kind of the anterior aspect of it. You might be able to visualize a grade 3 polyp, but not be able to see a grade 1 polyp on the other side. Now, you would expect this patient to have symptoms that are bilateral, because nasal polyposis is, as I say, as a result of chronic inflammation of the nose and paranasal sinuses, and by nature they are bilateral. Still, if that's going to flag with you as a potential unilateral feature on examination, if you can see something on one side of the nose and not on the other, then I have no issue with you treating that as a unilateral presentation and referring to ENT just for the sake of safe practice. That brings us to the end of the section on the nose. As you can see, it's distinctly shorter than the section associated with the ears. I think that's purely because of my personal preferences. I find that the ears really fascinating, really interesting, so I like to spend a lot of time on them. And we're now moving on to the throat. On the next slide, we'll actually see an image that represents what we're able to examine and inspect in class. But this first slide is more about the larynx, which we can still examine by listening to the quality of the patient's voice and by understanding how the larynx works. So anatomically, the larynx is, well, essentially it's what we refer to as the voice box, so a series of muscles and cartilages whose role it is to move the vocal cords. The larynx also has some function in swallowing, so the larynx moves up and forward when we swallow, and it abuts to the epiglottis here, this piece of cartilage that the role of which is to cover the larynx when we swallow, so that it precludes food boluses and fluids and secretions from traveling through the vocal cords and into the lungs. But our larynx itself, as I said, is this series of cartilages and muscles that control our vocal cords, and you can see them here. This is a view. This is actually closer to, well, this is the sort of view that an anaesthetist would be able to see. So in anesthesia, they see the vocal cords in this A sort of shape, so A for airway, whereas actually in ENT we tend to view it from a slightly, well, a mirror image, but mirrored vertically, so that we see a V for voice. So the vocal cords would actually be facing the other way. But what we're seeing in this image here then is that we have the epiglottis anteriorly, so that's the epiglottis here. So actually the patient's facing in this direction, with the back of the patient's head over here. The role of the vocal cords then is that they move apart as we breathe, so they abduct. Okay, so they open up, meaning that this space between the vocal cords here will get wider as we breathe in, and then as we speak, the vocal cords are pulled together, so they adduct. We get adduction of the vocal cords. And again, there's some videos for you to watch here. That you can watch a video of nasolaryngoscopy that's actually taken during surgery. So this top link here, if you click on that in the slides and watch that video, you'll be able to see a patient undergoing laser surgery to remove a papillomas or wart, basically, from one of their vocal cords, and that will present with vocal hoarseness, with very few other symptoms, really. That the patient will say that their voice has become more hoarse, it doesn't sound the same to them, or sound have this husky quality. That's not the only pathological process we can pick up on by listening to our patient's voice and inquiring about the changes. In fact, one of our red flags for head and neck cancer is voice changes. So we actually inquire about any voice changes. We want to know about weight changes, in particular weight loss, unexplained weight loss, and that's quite a common red flag throughout multiple cancers. We also want to know if they found any lumps in their neck. So we want to know if they have any neck lumps. Now, patients will always have found them, even though they might have something there. But if they've actually noticed themselves that they have a lump in the neck, then that needs to be taken seriously. It can be an indicator of head and neck cancer. It may not be. We can get reactive lymph nodes in the neck, and although I'm not talking about them very much in this presentation, we'll look at those in class with regard to the examination. We also want to know about any swallowing problems, so dysphagia. Okay, so there are four main red flags with regard to head and neck cancer. With regard to voice changes, on one of the next slides, there's a video for you to watch that it discusses the recurrent laryngeal nerve. So that's a branch of our 10th cranial nerve, which is the vagus nerve. The video will show you how, not just in humans but in other mammals as well, that the recurrent laryngeal nerve travels from the brain all the way down into the chest, and it loops around the aortic arch, and this is on the left side at least, and then it goes back up out of the chest and innervates the larynx and helps us move our vocal cords. So inquiring about voice changes, one of our differentials here needs to be lung cancer. I've actually seen a lady in the past in ENT who presented with vocal hoarseness, and one of her vocal cords was fixed in a lateral position, what we call the abducted position. So she had a unilateral vocal cord palsy, so that means that one of the vocal cords isn't moving properly. And so as the other vocal cord tries to meet it in the middle in order for the cords to vibrate against one another when we speak, it isn't able to, and so we get this sort of breathy hoarseness of voice. Speaking of the function of the vocal cords, if you click on, in particular, this third link here, the stroboscopy video, you'll see very clearly how the vocal cords work in a healthy patient and how they come together, they adduct into the middle, and they vibrate against one another. Stroboscopy is really fascinating to watch because as well as the light from the endoscope is linked up to a microphone that picks up on the frequency of the patient's voice. So as the patient in the video is saying "ee," that's what we call phonation, that forming of voice, and the microphone picks up on that same frequency, and the strobe flashes at the same frequency as the note, and so we get this sort of slow motion video, and you can see how the vocal cords move like a wave as they vibrate against one another in order to form voice. With regard to the rest of the anatomy here then, as I said, we have the larynx, which is our vocal cord, our voice box even, including our vocal cords. We have our epiglottis. We also have our oropharynx here, and then superior to that we have our nasopharynx. We've already talked about the nose, and then this part here we have our oral cavity. Our oral cavity is the part of the mouth that we're going to be inspecting in class. These are our key landmarks here. If you look at your instructions for the structure of your examination, it mentions inspecting the dentition. So we want to illuminate this area so we can inspect the teeth to see whether or not are they in good condition, are there lots of fillings, is there quite a sort of evidence of poor dental hygiene. We want to examine our buccal mucosa. I'm going to change colour. Our buccal mucosa here and here. We want to use our tongue depressor to move this soft tissue of the lips out the way so we can inspect the gums for any signs of gingivitis or any other oral lesions. We also want to ask the patient to lift their tongue up out the way so we can inspect these salivary ducts in this sublingual area here. We can then ask them to place their tongue back down again so we can inspect the superior structures, including our hard palate and our soft palate here, including our uvula. Our uvula is this middle sort of dangly bit of soft tissue that should be central. We also want to inspect our palatal tonsils here, which are bilateral. We'll talk more about those in a minute or two. And we can also inspect this posterior oropharynx or posterior pharyngeal wall here. So we're making sure that we're illuminating this whole area, and that's really important because environmental lighting just isn't good enough to be able to get a good view and pick up on any subtle lesions. I'm not really even talking in this presentation, I'm not covering oral lesions. Really, as a rule, we're looking for white patches, but there's lots of differentials around that, and I'm not really getting into that here. We can always try and cover that elsewhere, but as I said, the purpose of this presentation really is to give you an introduction, and there's only so much I can cover in this time. I mentioned the uvula previously, and this is going to be a key indicator with regard to diagnosing peritonsillar abscess. Excuse me, because if we look at this diagram here, it mentions the displaced uvula. Before we get into that, we'll define what peritonsillar abscess is. I've accidentally overlooked that. Now, it's a complication of tonsillitis. So tonsillitis is an inflammation of our tonsils. Now, we're actually referring to our palatal tonsils, which are the ones that we can inspect, that we mentioned in the last slide, that we can see as we inspect the mouth and oropharynx. Now, they're not the only tonsils. Actually, they're a bilateral set of lymphoid tissue that exist within the oropharynx. We also have lymphoid tissue at the base of the tongue. We have lymphoid tissue at the back of the nose and around the opening of the eustachian tube. And this creates what we refer to as Waldeyer's ring, which is an active part of our immune system when we're children, but it isn't active when we're adults. So tonsillitis tends to be an age-limited pathology, that as people get older, they are much less likely to experience tonsillitis. So it tends to be a younger age group of children through to people in their 20s. Peritonsillar abscess is a complication of tonsillitis. So essentially we're talking about a abscess formation in the tissue around a tonsil. So perhaps the soft palate, for example, here. So in this patient, we've got this formation of an abscess here, and that this is pushing the uvula over to one side. And that's what we refer to as lateralization of the uvula here. Clinically, these patients will present having had symptoms of tonsillitis, so they will complain of difficulty swallowing. There'll usually be a few days history of pain in the throat, and they'll say that the pain started sort of centrally or on both sides, and then very sort of soon before they present, they'll describe the pain having moved over to one side. So for this example in this image here, this is on the patient's left side, they'll be complaining of severe pain over on the left as a result of this abscess on the left hand side. So the pain goes from being bilateral to being distinctly unilateral. They will tend to have dysphonia, so voice changes, in particular what's referred to as a hot potato voice, so sounding as though they have something in their throat, and it's a very distinctive sounding voice. I'm not going to do my impersonation of that now. I might treat you to that in class, but it's one of those once heard, never forgotten things. Once you've heard hot potato voice, it becomes then a really good sort of heuristic indicator for diagnosing peritonsillar abscess. These will usually be people who are demonstrating signs of being quite acutely unwell. They're usually ambulatory, but they're usually unable to swallow. They might be able to not even swallow their own saliva, so they might be spitting their saliva out into a bowl. It's quite common for people with sore throats to tell you that they're unable to swallow, and it's important to be able to differentiate between people who truly can't swallow compared to those who are able to manage a bit of diet and fluids. So as your patient says, oh, I can't eat anything, we want to make sure we're asking the right follow-up questions to differentiate between, for example, asking, what have you eaten today? If your patient says, oh, I had a little bit of breakfast, but it was really difficult, that is distinctly different to the patient who says, I haven't eaten anything because I legitimately cannot swallow. And that will be one of your indicators for peritonsillar abscess. Again, going back to the slides, there's a link here for some more information on diagnosing and treating peritonsillar abscess. But the definitive treatment here is usually either needle aspiration or incision and drainage of the abscess. Rarely you might see what they refer to as hot tonsillectomy, so they might actually take this patient straight to theatre to remove the tonsil. That's unusual. It's more likely to be that they will incise and drain the peritonsillar abscess, treat the patient with IV fluids and IV antibiotics, and then list them for an elective tonsillectomy further down the line once they're well. What you can see here is examples of being able to grade tonsils. So we've got the actual photographs on the left that correspond to the diagrams on the right. A grade 0 tonsils is when they've been surgically removed. So when patients are consented for, when they're completing the consent forms with the surgeon for tonsillectomy, they will be told that one of the benefits of having tonsillectomy is that they won't get tonsillitis again. They can still get sore throats, but we can't diagnose tonsillitis if people don't have tonsils. So it's important for us to inquire about that. If patients present with sore throat, we want to know if they even have tonsils, and we can see that in on our examination. What we can see here, these pillars. So I've just drawn these blue lines around our posterior tonsillar pillars. And then if I switch to green, I'll draw a line around this anterior tonsillar pillar. And if we go to this next diagram, we can see then that our tonsil sits between these two tonsillar pillars here. And this grade 1 tonsil just sits between these pillars and it doesn't extend beyond them. Our grade 2, although it's fairly poorly demonstrated in the diagram, it just extends to the sort of the outer reaches of the tonsillar pillars. Grade 3 extends beyond them, and grade 4 they're extending to the midline. And it's easy to forget that in ENT we're also dealing with airways, and that's a really important part of our assessment of the patient. And in particular, if you look at this image, I'm drawing a square around here on the left, this image E, you can start to appreciate that with huge inflammation within the tonsils, that this patient's at risk of losing their oral airway here. And so we need to take account of that when we're deciding whether or not we're going to send someone home, or are we going to actually make sure that this patient's cared for in an environment where we've got airway support. That brings us to the end of this video lecture. You can see there are a few references here. I've tried to indicate those throughout the slides, as well as the formal references here. I've indicated where you can click some of the links in order to follow some of the sources and the useful information around ENT. And I hope this has been a really good introduction to ENT. I'm aiming for it to be fairly comprehensive, although I'm sure that there's lots of other things that we could discuss as well. If there's anything additional that you'd like to see in here, please let me know in class. And just any feedback that you have on whether or not this was useful, which I hope it was, just let me know. But thank you very much for listening. I know it's quite a long one, but as I say, hopefully it's been useful and worthwhile, and I look forward to seeing you in class. Thanks again. Bye.